So I'm going to talk today about what I think the evidence suggests are the best ways to improve outcomes and reduce costs for high needs patients based on work I've been doing in this area for about 20 years. And it won't be exhaustive, obviously. It's much too broad to cover in 10 minutes or even 10 journal articles. I was going to say there's a spoiler alert that there's no magic bullet, surprise, surprise, for high-risk patients. Obviously, one of the reasons is the heterogeneity of the populations, for one, but also the care setting and the insurer. So the work I'm going to talk about today is mostly what my colleagues and I have been involved in because that's what I know the best, but I'll also draw on a fair amount of other work, mostly for Medicare and Medicaid because that's where most of the high needs patients are and the best evidence for the most part. So I'm going to skip most of this slide because it replicates much of what Melinda said. The groupings, mine match up with hers pretty closely, and you've heard a lot about the heterogeneity of the high needs population. And there are different needs, and so the best model obviously is going to vary because their needs vary. But it also depends on settings and payers. Is the patient in the community or in an institution? Are they in fee-for-service, Medicare or Medicaid, or in managed care, or somewhere in between, like in an ACO? And the needs and the goals of patients vary a lot, even within these groupings. But I do want to illustrate that heterogeneity a little bit using dual eligibles as an example. Duals are always considered a high need group, but as you can see from this slide, they vary a lot from this really expensive group with extensive physical and behavioral health problems and who are in nursing homes to the nearly 40% of duals who are poor and old and thus qualify for Medicaid and Medicare, but they're not that sick. Between them, there's these two community dwelling groups with chronic illnesses, characterized, some of whom need long-term support services that have to be integrated and coordinated, and some that don't. The slide also identifies some programs in both fee-for-service and managed care settings that have evidence of being effective for the subpopulations. These are not exhaustive lists by any means, and I don't have time to talk about what these programs do. But there's a fair amount of published and gray literature on each of them. But the quality of evidence varies a lot about what works. The strongest evidence is for transitional care interventions to reduce 30-day readmissions, and there's a number of randomized controlled trials that show reductions of up to a third in those readmissions. And that's great. Transitional care models are terrific and needed, but they deal with only a very limited slice of time, not the long-term needs of these chronically ill patients. I think what we want to do is prevent the train wreck, not just ensure that the repair is done well. We also have pretty good evidence about what works in Medicare fee-for-service I'm going to talk about in just a minute. There's a lot of studies that are coming out in the journal, American Journal of Managed Care and other places about what MCOs are doing about their effectiveness. But some of those research designs are pretty weak, so I think some of them have to be taken with a grain of salt, others not. So I'm going to talk for a few minutes about the best evidence we had from Medicare fee-for-service, which is mostly from an evaluation of coordinated care demonstration that my colleagues and I did for CMS. There's a randomized controlled trial in each of 15 sites. Each chose its own high-risk population of people with chronic illnesses in Medicare fee-for-service. They developed their own interventions. And in this study, the care management was provided by entities that were independent from the primary care physician. And only 2 of the 11 programs that enrolled enough people to be even evaluated reduced hospitalizations for an already high-risk group of enrollees, but 4 of them did so by 11% a year from 2002 to 2008 for their higher-risk enrollees. And we looked at a variety of different definitions, but the most consistent definition for which we found things, and we were looking for something we could use in claims data. It's pretty easy to identify patients. And those are people that had conditions that were associated with high hospitalization rates and that's severe enough as measured by whether they had a prior hospitalization in the year before. coronary artery disease, congestive heart failure, and COPD were the three conditions, or they had that and a prior hospitalization or multiple hospitalizations in the prior 2 years and one or more of 12 chronic conditions. So targeting is pretty critical. So what is it that distinguished these 4 coordinated care programs that were successful in reducing hospitalizations from the 7 that did not? What did they do differently? And it's worth noting that it wasn't the type of organization. It was 4 different kinds of organizations. One was an academic medical center in the middle of St. Louis. One was an integrated delivery system in rural Iowa. One was a home health hospice agency in Arizona. And one was a nonprofit quality improvement organization in Pennsylvania. So we used information that we gathered in site visits and interviews to identify features that at least 3 of the 4 successful programs did and none or maybe only 1 of the unsuccessful ones did. And we found 6 things that these successful programs did that care coordinators in the other programs didn't do. They had monthly face-to-face contact with patients as well as telephone calls outside of physician office visits. They built strong rapport with patients, physicians through face-to-face contact at in the hospital or by going to the office visits with the patient. They used behavior change techniques, not just patient education, but they used readiness to change or motivational interviewing to really engage the patient in changing and overcoming the particular barriers that they were facing to doing the self-care that they needed to do to get better and to keep from declining faster. Fourth, they knew when patients were in the hospital and provided support for this transition home. One of them used something they called Naylor Light for their transitional care program. A key thing, they acted as a communication hub for the many providers that these chronically ill patients saw, and between the patients and the providers. They did some translating. Last, they had effective medication management, which included reliable information all the time of what the patient's medications were and access to pharmacists or medical directors when issues arose about their medication, either brought up by the patient or noticed by the care coordinator. There are other factors that matter too. These weren't the only ones that are necessary, but these are the ones that distinguish the successful and the unsuccessful ones. And we also found there were also a couple of things that didn't matter. One of them was whether they had an electronic health record system, but that was 2002 to 2008, so that might be quite different now. Nobody denies the potential value of EHRs. And the other ones was whether they paid the primary care physicians for cooperating with the care coordinator. Many of the same features that are present in that we found successful are present in some managed care plan models that show some evidence for improvement. Geisinger's Navigator patient-centered medical home model has a lot of these same features. Embedded care managers, they work with primary care providers to identify and work with the truly high-risk cases that come out on the list that they see. They have links to acting physicians at other care sites so that they have this communication hub going. But they also found that shared savings to be meaningful. Another model that's has some promise is the comprehensive care physicians model that moves away from hospitalists to improve the continuity of care. They send all their high-risk patients, high-need patients to a small set of providers and limit the panel size they have so they have enough time to spend with them. And they use interdisciplinary teams and data-driven meetings, and they too have a shared savings incentive. Rutgers has also just come out with a paper with a series of recommendations for high-needs Medicaid patients, this top 1% that account for half of all costs, and they have medical illnesses and or substance abuse problems. But I wanted to raise a question too, though. When all this earlier work was being done, hospitalization rates were high and pretty stable for Medicare fee-for-service. Lots of preventable hospitalizations, but in the past couple years, evidence has come out that showing this rapidly declining rate of Medicare hospitalizations from 2012 and 2013. It's not clear what this is attributed to. Is it the expansion of initiatives like primary care redesigns? There's a bunch of that going on. The spread of accountable care organizations, improvement of electronic health records, hospital penalties for readmissions. So you can imagine, you could probably make up a bunch of other ones as well that might be in part responsible for it. But the message here is that for care coordination programs to have a net effect, on top of all the other things that are going on, and to justify their cost, the bar's risen. They have to do better than what other changes are already accomplishing. And a good example of this that I want to talk about is Health Quality Partners. That was the most successful of the coordinated care demonstration programs from 2002 to 2008. Decreased mortality as well as costs and big effects on hospitalizations. It was extended through 2014 for the subset of high-risk patients that it had the big effects for. We found no effects over those 4 years for the newer existing patients. After 8 years of these very favorable effects. Everybody's terribly disappointed in this. And so we've explored a lot of reasons for this. And the only explanation that we could find that was consistent with the data and with our talks with the program leaders, who were very generous with their time, was that the new treatment group had very similar risk-adjusted results as the earlier period, but the control group, the new control group, had substantially better results than the control group did before, after any risk adjustment for possible differences between them over time. So to the point where their outcomes were now very similar to the treatment group. So moving forward, there's a lot of work yet to be done on improving care coordination. Last slide, I promise. So there are approaches that work, but what works clearly differs across target populations and settings, and it costs money. We need to find the most efficient and effective ways to provide it. And this slide lists some of these components of that, because we don't know how you do care coordination matters a lot, and we don't know the best, the ideal duration, the optimal coaching methods, all those the best screening tools. So I think what we need is some efficient orthogonal designs, fractional factorial designs that large organizations, ACOs, and managed care plans can and actually are doing on their own. To figure out how you do things, how that affects the results. We did this with the special needs plans. We assigned their 24 care coordinators to specially selected combinations of 8 different features of a care coordination program, and then looked to see which ones were associated with better hospitalizations and emergency room use. And so I think this has a tremendous potential for healthcare organizations to learn quickly about what works for their population and in their setting. So thanks. The last couple of slides are just some references and funding sources. Thank you.